وانا النهارده بس مكلفه من رئيس القسم الدكتور مصطفى شاهين لان هو عنده شهاده محكمه يعني، فشرفني طبعا ان انا ارحب بيكم في الاجتماع الشهري بتاعنا واتكلم انجليزي بس عشان Welcome to our monthly meeting. I'm here on behalf of our head of department, Professor Mustafa Shaheen. It is a real pleasure to welcome you all and to welcome our guest, Professor David Barwon. And as we are used to, before we will start by the national anthem. Assalamu alaikum. هي الندوة شغالة عن الادكشن psychiatry actually معلش الإعلام مش دايما واضح and it is a real pleasure for me to introduce Professor David Barwon. He is the former Deputy Clinical Director in NIMH, okay, the Department Chair Psychiatry in Temple University of Southern California, the Provost, أو إحنا هنا في مصر بنقول Rector, and Senior Vice President for Western University of Health Sciences. We can go on for half an hour at least to say the most important bits about his CV, but thankfully he has agreed that we can keep it short. I think it's better to listen to him than to listen to me saying what he has done. He has accomplished a lot, I am sure. The title of his talk is Opioid Addiction, Intra-Professional Education. And I will leave the mic for Professor Barwon to tell us about this very interesting topic. الحقيقة أنا كنت في موقف صعب شوية، كان بيسألني يتكلم عن إيه أحسن حاجة وأنا حسيت إن أنا ما أقدرش أقول بدلكم فقلت لهم من كل بستان بره، بعد كده يبقى في discussion, okay?
Well, thank you very much, and thank you all for coming. I do a lot of work in the field of sport, and whenever you hear your national anthem, it means you were the champion, that you won. So hopefully we will all win today, sharing with each other some thoughts about what has become one of the world's greatest public health epidemics, and that's the area of addiction, and particularly in opioid addiction. As psychiatrists, we focus primarily on how people think, how they feel, and how they behave. Drug addiction addresses all three of those issues. People oftentimes take drugs because they have uncomfortable feelings, or they take drugs because they want to get high. The behavior of taking drugs, injection or by mouth or through the nose, is a behavior that most people think we can stop. In fact, in my 38 years in psychiatry, and I actually started doing addiction research before that, before I became a psychiatrist. I never once met a patient who told me their life goal was to grow up and become the world's best addict. No one comes into this world wanting to become an addict. It brings shame on the family, shame on themselves, disrupts their family, very rarely leads to anything good in their life. Yet, when people become addicted, they cannot control the behavior. We know that drug addiction is one of the most recurrent illnesses. Worldwide, drug addiction has significant stigma. Drug addicts are not viewed as good, honorable people. They're involved in illegal activities to support their habits. Their families are oftentimes ashamed or embarrassed by their behavior. They underachieve in life at every level of life. So why is it that something that we know has such a negative effect on life has become the #1 public health issue in the world? Why is it that we know what taking drugs does to your life, to your health, both physical and emotional, and yet people use? And unfortunately, the data on opioid addiction worldwide is only going up. Despite all the science, all that we know about the effects of drug addiction, it continues to rise. I believe when we look at addiction, we have to understand this as a classic biopsychosocial problem. It has to do with many factors. Much of my recent research has been on understanding the biology of addiction. So we now know that we have individuals who are at greater risk for drug addiction based on genomics. We know that there are candidate genes that put one at greater risk. Why is it that some people can try cocaine, other drugs, once, twice, never become addicted, and others become addicted? Well, we now know that there's a very important genetic component. Just like our expert in ADHD, we know that there are a number of candidate genes that put an individual at higher risk for ADHD, for cancer, for heart disease, and for addiction. So we're getting very close to be able to screen individuals who might be at higher risk based on a series of candidate genes. Now, why that's important is because if we know someone is at higher risk for addiction, maybe we can intervene before they become an addict. Identify a high-risk patient population. And this is what we're doing. We know a bit more about the addiction biology. We know the effects of dopamine as the reward pathway. Mesolimbic dopamine becomes a very important issue. Now, why is it important to understand the biology of addiction? Because if we don't understand the biology, we will not be very effective in coming up with effective treatments. The treatment of addiction requires more than just medications. Medications might play a role, but it's one piece of a much bigger puzzle. The role of the family, the role of psychotherapy, the important aspect of keeping the patient engaged. All the data worldwide has demonstrated one thing consistently when it comes to the treatment of addiction. And that one thing is not one particular medication. What that one thing is having the patient stay engaged in treatment. That is the best predictor. So patients who leave the hospital against medical advice, who don't come back for their outpatient treatments, they are at the highest risk for relapse. So biology can help us to understand why people would do something that they otherwise know is going to have a very bad effect on their life. Biology also helps us to understand craving. Why do people take drugs continuously when they know the negative outcome, when they know what this is going to do to themselves and to their families? And the answer to that is craving. I must take the drug. Now, we all know craving at a small level. I crave a piece of chocolate. When you crave a piece of chocolate, you'll look until you find that piece of chocolate and eat it. Or I crave a nice shawarma sandwich, you'll find it. But drug addiction is craving times 100. That people are driven, they will do anything to get the drug, even though they know it is likely to have a negative effect. So it turns out, understanding the biology of craving, what makes people feel like I must use whatever, I'll steal money from my family, from my friends, from the store to get the drugs. So as we understand craving, we start to understand how do we develop effective treatments, because there are very few effective treatments. It's like cancer. When I started my medical training, there were very few treatments for cancer. Most people ended up dying. Now, because of excellent research, there are many treatments for cancer. Many forms of cancer are actually curable. This was not the case 35 years ago. So, one of the things that I would like to do, and I want to make sure we have a lot of time for questions so that we can communicate with each other. Because one of the things that's very important in drug abuse is understanding the impact that culture has. Egyptian culture, culture in Cairo, very different than Los Angeles, where I live, where my university is. Effective treatment requires an understanding of culture, of religion. Oftentimes people will question, how has God done this to me? How has God allowed me to become an addict? And they will get angry, but then they will feel guilty. So effective treatment requires not only a knowledge of the biology, which will help us develop new treatments, but an understanding of how culture, how relationships affect the individual's continued use of drugs of abuse. One of the things I'm very interested in doing, working with my dear friend Professor Samir, we've been friends for many years now, since 2005, is developing a training program for residents, faculty, in the treatment of addiction with my university in Los Angeles, so that we can understand how to best diagnose early and treat addiction, so that hopefully someday we will look at addiction the way we now look at cancer. In many ways, a treatable disease. Unfortunately, addiction affects many things other than just using and getting high. It affects overall physical health. The effects of drugs of abuse. They're not pure drugs like we get from the pharmaceutical industry. These are drugs that are contaminated with many other substances. In the US, we call them adulterants. It's putting something in, and oftentimes it can be rat poison. Anything that looks white to make it look like cocaine. Very interesting to me, and I've had this discussion with Professor Samir, is that although hashish is probably the #1 drug of abuse in Egypt, tramadol is very high on the list. Nowhere else in the world. Tramadol abuse almost non-existent in the United States because it's considered a milder form of an opioid. So there's something about tramadol in Egypt that has it so high up on the list. For a while, I thought maybe this was because a number of years ago, there was a report that was untrue that said that tramadol increased sexual performance. Not accurate, but it was on the internet. And I thought, well, maybe people thought that they were abusing tramadol for sexual performance. It doesn't work, but there's no data to demonstrate that. So I believe there's a wonderful opportunity for my university. We are the largest, most diverse health science university in the United States, to work with our brothers and sisters and colleagues here at University of Cairo to develop advanced training, master's programs, certificates, so that we can advance not only the science of addiction, but the clinical care. I believe when it comes to addiction, every member of the healthcare team, nurses, psychologists, social workers, need to be knowledgeable about what to look for, how to identify addiction behaviors. Because we know, just like with all other chronic diseases, the longer it goes without being treated, the more difficult it becomes to treat. If we identify addiction in adolescence and intervene, then we very well might be affecting a lifelong problem with addiction, because as the adolescent becomes older, the addictive behaviors, addicts tend to identify with other addicts. We see this with ADHD, that ADHD youth oftentimes will affiliate with other ADHD youth because they feel they understand them more. Addiction addicts tend to socialize. They spend time with other addicts, which reinforces the behaviors. So I believe there's a wonderful opportunity for us to learn from each other, to gain special expertise in this disease that really has become, in many, many areas, the number one health, not just mental health, but one of the number one risks to health worldwide. So what I'd like to do now, we could talk about the biology of addiction. I do a lot of research in this area, but what I'd rather do, since to save our time, we made a couple of short videos. Hopefully we can get them to show here. This is an example of some of the online learning. So we can develop a training program that people will not have to travel to the United States. They won't even have to travel to Alexandria. They can stay here in Cairo in front of their computers. We've developed very advanced online learning, which we try to make it fun, not just boring slides or listen to a boring lecturer, but interactive, gamification, so that learning becomes more like a game. We found our younger students, the age of my sons, 31 and 35, they learn better when it's interactive. They watch Netflix, not TV. They want to watch what they want to watch when they want to watch it. So we have online learning that will allow individuals to learn at their own pace, gain expertise, knowledge, and skills, and then advanced certification so that they can use that in their clinical practice regardless of where they go. So we train nurses who obviously get involved, internists, surgeons. In fact, what we found in the United States is one of the big issues in opioid addiction were because of physicians. Physicians who overprescribed pain medications. A number of years ago in the United States, they talked about the fifth vital sign. What the fifth vital sign was pain. And the idea was all of our patients should be pain-free. Well, as we know, sometimes to make someone pain-free requires very high levels of opioid medications. And in fact, drugs like oxycodone, is there oxycodone here in Egypt? No?
No.
Highly addictive drug. There are now the drug companies in the U.S. are being sued for billions of U.S. dollars for pushing the use of opioid drugs and creating, which is a public health disaster in the United States. So I'd like to close the comments. We can maybe show the short film, and I know I encourage you, even if your English is not so great, my Arabic is non-existent. So please ask a question. We have two translators up here. It would honor me to hear your questions, your concerns, and your thoughts. So, sir, if you could please, let's try that. I brought a couple of them over. I'm not sure which one this is.
Opioids include the opiates, which are the natural alkaloid. Opioids are substances. The impact of opioids on your brain and body. Opioids are substances that produce morphine-like effects. They are used primarily for pain relief, although there are multiple uses for these medications. Opioids include the opiates, which are the natural alkaloids derived from the opium poppy. This class of drugs also includes synthetic drugs, antagonists, and endogenous peptides such as endorphins. When we take opioid medications, they enter the brain and bind to opioid receptors on cells located in many areas, especially those receptors involved in feelings of pain and pleasure and in controlling breathing and hormone release. The chemicals in the opiates attach to specialized proteins on the surface of the neurons. There are three types of opioid receptors: mu, delta, and kappa. It is the mu receptors that are responsible for the pleasurable and analgesic effects of opiates. Opioid receptors are located in the brain, brainstem, spinal cord, intestines, and other organs. When endorphins, our body's naturally made opioids, are released, or when opioid drugs are taken, they bind to opioid receptors in the brain and body to regulate functions including pain, pleasure, breathing, and digestion. Click on the body part to learn about the effects of opioids on that system.
So at this point you could stop and then click on each one at your own pace. We just want to do this as a demonstration. Should keep moving. We'll start right here. So this is just an example. Hopefully we can get it to go through, but this is online learning that hopefully is more engaging. Be a little music that makes it a little bit more encouraging, and these are very...
The linkage of these chemicals with the receptors triggers the same biochemical brain processes that reward people with feelings of pleasure when they engage in activities that promote basic life functions, such as eating and sex. The activation of the reward center is the primary reason opioids can lead to addiction. One of the brain circuits that is activated by opioids is the mesolimbic midbrain reward system. This system generates signals in a part of the brain called the ventral tegmental area, VTA, that result in the release of the chemical dopamine, DA, in another part of the brain, the nucleus accumbens, NAC. This release of DA into the NAC causes feelings of pleasure. Feedback from the prefrontal cortex, PFC, to the VTA normally helps us overcome drives to obtain pleasure through actions that may be unsafe or unwise, but this feedback appears to be compromised in individuals who become addicted to drugs. Dependence is the need to keep taking a drug to avoid the effects of withdrawal. The effects of withdrawal impact most body systems, just as most systems are affected by opioids. Click on the body part to learn about the effects of dependence on that system.
You could stop and click on any body part you'd like here.
Addiction is the intensive craving leading to compulsive use. Addiction results from changes in the reward system of the brain. Treatment for addiction requires a comprehensive, multifaceted approach that includes behavioral therapy, family counseling, support services, and medication. Pharmacological therapy used in medication-assisted treatment, MAT, is a critical part of care for opioid use disorder. These medications reduce the symptoms of withdrawal and may reverse some of the brain changes associated with addiction, greatly enhancing the effectiveness of behavioral therapies.
So I actually brought a few other examples, but I think I'd rather, in the sake of time, I have about 10 more minutes. So we have an entire curriculum that is this type of, high-end graphics, and the learner can stop at any point and review it, go over the individual body signs. So there's actually, this is one tiny piece of a much larger curriculum in gaining knowledge and skills and expertise in the role of opioids. And some of them, again, you can see I brought many of them here, but I'd much rather hear from you and hear from our respected colleagues here. So let me just stop. We have, according to my watch, exactly 10 minutes. I wish we had more, but I don't want to take away from our other presenters. Please, questions, comments, ideas, and please, you cannot offend me. The only offense I take is not asking any questions. Thank you all very much. I hope we get a chance to work together on education and training with your prestigious Kasr University and my University of Western U, inshallah.
They can ask the question now.
يا أسئلة حضراتكم تحبوا تسألوها حتى لو بالعربي واحنا بنترجم. اتفضل يا دكتور.
I'm not sure I quite grasp this. Is this for undergraduates? This is for undergraduate training?
We have the training everywhere from, so there's different versions. We have it for nurses, social workers, undergraduates, residents, junior faculty. We even have a version of it for senior faculty. So each level enhances the quality. So, but we have many different versions. It's just like, you might take pharmacology as a medical student might be different than an advanced pharmacology course if you're already associate or a full professor. So we've developed many different levels. For the master's program, it's a little higher level. But the advantage
of having many is that people at many different levels can engage. And it's meant to be enjoyable, to have it be fun. Now we do have assessments that measure not only, we're not interested in how many questions did you get correct, which we normally have in medical school, but are you competent? Do you have the knowledge and the skills and the behaviors to take care of addicts? So we have, the assessment is something that is, it's computer adaptive learning, but it's a way to make sure that people have the competence without feeling nervous that I passed the test. So this is advanced learning styles that we do a lot of. I have over 20 people in my university that only work on the computer version of measuring competence. Thank you.
I think we have with Professor Maha, the head of the addiction unit, a program to the house officers, to the 1,500 graduated house officers every year. So can we talk to design a program for the physicians all over the country? Because some of our obstacles with our patients in psychiatry or drug addiction are the pharmacists and the physicians. Don't take this and don't take that, it will make an addiction. Or did you apply for physicians, non-psychiatrists?
Yes. Yes. At my university, we have 9 different health colleges. So your question is very important, because one of the things that we see is that individuals who want to treat sometimes make things worse. So what we want to do is train everyone. And we have this developed. And the advantage of being online is we could train 1 million people. All they need is a computer. So
the reason we developed this, I got a very large grant from the United States government to help us develop this. So it's always easier when you get let's see, it would be $1 million, would be a little over 17 million Egyptian pounds. But it's meant for physicians, for internists, family physicians, surgeons, residents. It is not just for psychiatrists. So we have versions that are appropriate for people at different stages of training and even in different disciplines. Nursing students, dental students, practicing nurses, practicing dentists. Dentists tend to overprescribe a lot of pain medicines. I don't know in Egypt, but in the US, someone gets a tooth extraction or wisdom teeth and they give them too many opioids. And we've actually been able to measure this in the United States. I'd very much like to measure it here in Cairo and in Egypt, but we found by training dentists how to use pain medications more appropriately, we've been able to see somewhat of a decrease. So the plan is to work with your university and train people, as many as possible, because it's very inexpensive. No one has to travel.
There is overprescription by the venereal specialist and the post-operative surgeons,
Yes.
whatever the...
Yes, so we have a very specific, at my university we have a college of pharmacy for PhDs in pharmacology. So to educate people how to use pain medicines in a way to limit the potential for addiction, or to identify the individual who might be at risk so that you would maybe not use opioids, use other forms of analgesic medications.
Professor Abdurrahman.
Regarding addictive substances and psychosis,
Yeah.
in my clinical setting, I observed that the most addictive substances less psychotic, يعني opioid, nicotine, less psychotic than cannabinoids and amphetamine, cocaine. What is behind this observation?
Yes, and in fact that's an observation that many have made. So your observations are consistent with what we've seen across the world. It's been very interesting. In the United States, there are a number of states where marijuana is now legal. Like California, where I live, marijuana is legal. What we've seen in our adolescents is an increase. People who use marijuana having their first psychotic break. So there's something about the biology of psychosis that seems to be related, that people with, as you say, drugs, marijuana is quite, amphetamines, quite common. That there's something about those drugs that seem to lower the threshold for a psychotic episode. But we also know from the work on sensitization and kindling that once you have that first psychotic episode, you have many more. And that we do know a little bit about the biology. Why it is that the opioids per se we don't see an increase so much in psychotic behavior, but what we see is a very difficult time stopping the use. So the repetitive behaviors, we think that has to do with the direct impact of the opioids on the reward pathway. So actually, if you're interested in this, I published the last year about 18 papers looking at the biology of reward systems called the Reward Deficiency Syndrome, RDS. If you Google, you'll see I've published many papers on that just the last year or two. It seems like the opioids do not trigger as much psychotic illness, but they very difficult in hijacking that reward pathway, the mesolimbic dopamine. Where in other drugs, we use, it seems, activation of tubuloinfundibular dopamine, which is more associated with psychotic illness.
Welcome, dear Professor.
Thank you.
This is an online training. Have you done any comparative assessment or assessment between the level of the trainee in official classroom training and the online training, you know, sitting with an addict requires not only knowledge, it requires tolerance, acceptance, skills, many things. The dropout can be because of the therapist's tolerance, because of the level of intervention, how far is it deep, how far is it superficial. So how can you assess that the online training would give professional therapists, professional nurses, you know what I mean, that can make successful therapy? Is there any assessment for the level of the trainee after the online training?
Yes, and your point is a very important one, because this is not meant to make an expert, but to give someone the foundation to then go and get the clinical experience. We all know in medical school, when we learn to do psychotherapy, we might learn the techniques. What makes us a good psychotherapist is seeing patients, is the clinical experience. So this is not meant to be done in lieu of clinical experience, but it's to give the experience to that be more effective, because we all know as clinicians, we learn how to do it by taking care of patients, by seeing the patients don't read the books. So we learn one way, but then we gain clinical experience by being in the clinic, sitting with the family, sitting with the patients. This is meant to build that foundation, to then build clinical experience, because one without the other is not as effective. So your point is a very important one. We don't want people to think, well, I've done this training and now I'm an expert. No, you have knowledge that will allow you to become a better clinician. Now, we have looked at online learning versus sitting in a classroom like this. And it turns out that if you do high-level online learning that we've tried to do here engaging, the younger generation prefer it and learn better because it's consistent with what they've grown up with. Older generations, gray hairs, like me, we are used to learning in a more, what they call passive learning. You sit there, you listen, you nod your head, you hopefully don't fall asleep, right? And then the exam comes and you hope you get 75% of the questions correct. What we're finding is in the younger generation, that style of learning is not as effective. So what we found is engaging, because the student, as you see here, they stop and they get feedback. They can literally ask. So it's not as much passive learning. It seems to be in many areas. We've actually done studies in Singapore and some other areas. So it seems to be a very effective strategy, but it's one piece of a larger puzzle. So your question is very good. So we tell people, now what you need to do is apply those knowledge and skills that you've learned, and then sit with an experienced supervisor and see patients and their families. So again, this is one piece. We think it's an important piece, but one piece of a bigger puzzle. The best clinicians are not the top students coming from medical school. They're the students who went on and have seen thousands of patients in their careers and understand the nuance of pathology.
As we know that opioid acts on a brain-reward system, acts on nucleus ventral tegmental area that releases dopamine, nucleus accumbens, as you told us, that accompanied by feeling of pleasure. Meanwhile, other brain areas associate this feeling of pleasure with external environment, but may excuse later on for craving. My question is, if there is any difference for the patient who is receiving opioid analgesics for pain and another one who receives opioids without pain, if there is any difference in the pathogenesis, in the neurobiological changes in the brain?
Yes, it's a very important question. So those who maybe couldn't hear in the past, is there a difference in the addiction that maybe is related to pain as opposed to someone who just wanted to get high? And it turns out that there is. Interestingly, the effects can be measured by the brain white matter, something called diffusion tensor imaging, fractional anisotropy. Now I know, unless you're doing DTI here, this is something that, but, so the answer is a very good question, because addiction does not come in one flavor. It comes in many flavors, like cancer. Many different forms of cancer. We call it cancer, but we know that there are many different, some very treatable, some lethal. Addiction, and this is what's helped us in understanding the biology, is that the individual who gets addicted from pain medicine has a different, as far as we can measure now, I would love to continue these studies here with you so we get a much larger N clinical samples, but that the biology of how the brain deals with it. And the fascinating area is it is almost exclusively related to dopamine, which is fairly rare. Usually we have norepinephrine, serotonin, GABA, but dopamine seems to be a really critical part of differentiating those. And what we've seen is the greater the genetic loading, the more likely it is to develop it with pain. So why this is important is we can very likely, in the very near future, and would love to study this with my dear friend Professor Samir here, is that if we can identify a group of children or adolescents who we know are at greater genetic risk, and we just tell them, maybe don't use opioids, use other, amphetamine, non-opioid treatments, because there is a difference, and in fact, in the treatment response, there's also a difference. So as we learn more about the biology of addiction, we will become better clinicians. And then I believe another important issue is the family supports. We talk about, patients who have a stronger family support system tend to do better in treatment, and we can measure that in the brain as well. We can measure how mesolimbic dopamine and white matter tracks, and we have this change in diffusion tensor imaging, which I have many slides on that, but they would be boring. So it's a very good question. We need to study them more, but the answer is yes, we think that is absolutely the case.
Welcome, Dr. David in Cairo.
Thank you.
Actually, I went to Los Angeles in 2010, and I stayed there for 5 months in ISAP. With Dr. Rick Rawson, Lisa Moni, and others, but unfortunately with me, however, I feel familiar with you too much. I have a comment here, which I know about tramadol in Egypt. The use of tramadol is for decreasing fatigue.
For fatigue.
They use it particularly among young adults who are ambitious and they wanted to work for 12 hours, 18 hours, and so they use it they feel safe about it, they can take a half a tap or whatever, but actually he usually goes in the trap of addiction as usual. The second, I want to ask your opinion about legislation of cannabis or marijuana in Los Angeles or elsewhere. What do you think about why? And if you have the decision in your hand, would you like to do or not?
Well, I can answer both of those, but thank you for in the U.S., amphetamines tend to be used more for a stimulant. A student wants to stay up all night to study, or they want to stay up all night to party. That the amphetamines are used as energy producers, not so. But thank you for that, because that helps me understand it a bit more. The story of marijuana is a very simple answer for me. The government did it for tax dollars. It was a financial. There is no data to show that it hasn't had a negative effect. The only people where it has a positive effect are the people running the marijuana sales because they're making lots of money, and the government who's taxing it. In the adolescent world, we've seen a spike in first episode psychotic illnesses. So if you look at the literature, if you look at the data, there is no argument the only minor argument they make is, well, if you're selling it legally, then it's pure. In other words, it doesn't have other bad things in it. This was the issue with MAT, which we saw on the tape. The use of methadone, which I know is not permitted here in Egypt. Methadone is just as addictive, is just as negative as heroin, but it's pure. And you're getting it from the methadone clinic. So it's not a treatment. It's a substitution treatment, but you can control, so allow someone to get other forms of treatment. So I think any physician, any addictionologist, any child psychiatrist in the United States who follows this literature will say the same thing. This is not a good thing for health. But there are political reasons. And as we all know, money talks. Well, listen, I don't want to take any lovely questions. I'm really looking forward to hopefully we can work together on training and developing that next level of experts with clinical experience so that we can address this problem to help all of our patients and educate all of our students and trainees. Again, thank you very much. We look forward to working together, inshallah.
Thank you very much. You had, I think, a lot of questions, and I think if we say we can have more, you will have more. Now it's the most difficult thing. How should I introduce my colleague? We have been together for 33 years, the three of us, Maha, Samir, and myself. 33 years together, wow. I think this is the longest thing I have ever done in my life, for 33 years. I asked Samir, how should I introduce him? And he said, handball player. So there is a nostalgia there. But Samir has always been interested in both training as well as in addiction and general psychiatry. And what he's presenting today is addiction medicine unit activities. So can we have?
Thank you, Professor Saad. Thank you, Professor Maha, for the last 33 years, last 7 years. And I know all the time that I'm older than you and Saad by 20 years. I don't know how. But thank you for accepting me with you. And I've learned a lot from you. You are heading by me by many steps. As you know, at that time, when we started the residency, I was a handball player. I was not indulged in the faculty of medicine or the residency years after I stopped playing handball. And you always taught me a lot in psychotherapy and how to have a sheet with the patients and how to tolerate patients. And I said, okay, thank you, but I'm going to the training now. And thank you for your wisdom and good advice that I've taken from you along that year. And thank you, Dave, for coming here and spending all that hours of flight and presenting your wonderful lecture to us. Professor Mustafa told me to present this, the work activities of our department. And the one who had the honor to present it is Professor Maha, who is the head of the department. And if we did some activities since we opened the hospital since 2007, I think there's a lot who helped us in the addiction unit, like Mumtaz Abdul Jawad, Professor Mumtaz Abdul Wahab, and Professor Tariq Abdul Jawad, and a lot of the residents who helped us to initiate this. Actually, in the slide الأولاني, I'll talk about educational activities, therapeutic activities, research activities, training, and projects that we are involved in, and cooperation with other areas of interest. In our addiction medicine unit that runs the activities in the units, we take care of 30 patients. Our unit has 30 patients. Some of them are, they get inside for free, and some they pay for it. And along with those patients and some master degrees and MD degrees, we run multiple activities. The first education activities is the teaching the addiction curriculum to the 6th year of the medical school, the teaching of the prevention and early detection of substance use disorder to the house officers in Kasr Ainy hospital. We teach lectures to the psychiatric residents. As you know, they are moving between the child psychiatry and the adult psychiatry and the drug addiction. We introduce the conference every week, 3 weekly case presentations with Professor Muhammad, Professor Abdul Rahman, and the colleagues with the effort of Rania. Practical case taking, the practical peer supervision, the group and the individual psychotherapy that's done in our unit. Of course, the teaching to the master degree and degree candidates, the teaching psychiatry to the undergraduate psychologists, and we have an eminent psychologist in our department in training and in actual practice. We have a good outpatient activity. We have 4 addiction clinics per week. 100, we see 120 patients per week. We adjusted 30 patients per day to give a good service. We usually do the assessment by the psychiatric resident, psychologist, and senior lecturer. He's present in the clinic each time. We apply the matrix program, 3 groups a week, 40 to 60 patients we see a week at the outpatient level. Urine screening before, it is an obligatory before we see them, to avoid mixing of someone who relapsed or having even relapsed with others who are still in control and sober. Individual psychotherapy, the family group psychotherapy, I think Dr. Rani is doing it once a week. The psychoeducation program, denial breaking to the families, to break all the defenses done by the families to see their sons and daughters are okay. Sometimes we prescribe medications to them if they pass through depressive episodes. Next, please. The therapeutic activities among the 30 beds, as I've mentioned, we see a pure substance use disorder patients, usually polysubstance abuse. We see cases of psychosis and mania. We refer them to the psychotic department for a while till being controlled out of the psychosis, and then they admitted to the program of the addiction unit. The detoxification measures, of course, motivational interviewing skills, the motivational incentives, 4 group therapists per week, and of course the Department of Psychology is giving us a good help every time. The daily morning organizational meeting to read papers, to talk about the emotions, any dreams, any craving activities or craving thinking to destroy it in the early beginning of the day. The reflection group by night, maybe after 6 p.m. 2 individual psychotherapy sessions. We splitted the patients all over all the residents, so each resident has to know about all the 20 or 30 patients, but he has 2 specific sessions with each one he's responsible on. The family group education. I think we introduced 4 or 5 years ago the NA meeting once every week on Friday. We did a lot of research activities, the addiction psychology oriented research, the addiction screening oriented research, collaborative research with other medical specialties, some researches with other departments in liaison, the collaborative researches with other psychiatric specialties, like the ADHD patients. Dr. Sarah, I was supervising her thesis, and 60% of the sample was having ADHD, adolescent ADHD, and other branches related to psychiatric specialties. The training activities goes to the residents, house officers, psychologists, social workers, the nurses, everyone is 6 months around training. Between the last 5 years, 12 training courses for addiction treatment professionals on different topics in etiology, assessment, management, interventional approaches were given. A lot of projects that we were indulged in, mainly it was the Fogarty project since 2012 till 2015, and one under it was training for geriatric addiction. As you remember, the people from Gaza, Dr. Rania, we forgot to write it, training people from Iraqi and Iraq and from Gaza, the UCLA Fogarty project, the ISAM, with the help of Professor Tariq Abdel Jawad, organizing ISAM International Addiction Certificate between 2005 and 2009. The international conference. Until now, this was the biggest conference ever made by the ISAM in 2005. At that time, the elected president of the ISAM was Professor Tariq Abdel Jawad, who is in the National Center of Addiction in Abu Dhabi now. The High Council for Drug Combating Egypt, house officers, training, psychologists, and recovering addicts. We cautiously trying to push the ex-addicts to help us in our treating program. There are pros and cons, of course, and the fear of the relapse. We have many joint activities with the National Council for Childhood and Motherhood Prevention and Anti-Drugs Program among school students. We have also an activities مع صندوق مكافحة وعلاج الإدمان. I don't know if translated to the box of نعم هو ده الهيكل. It's not the box. Next thing. The cooperation activities, the psychiatric department of Sohag University, and it was a breakthrough activity with Sohag, and the syndicate in Sohag called us, and there were problems for transferring 25 doctors from Sohag to here, and Professor Maha created a breakthrough idea that we go to Sohag every weekend for Thursday, Friday, and Saturday to teach there, and it was a nice trip to all of us with a. Yes, they came after to training in the outpatient and the inpatient. We did a training to Mansoura University, to the Tanta University, to Munafia, all the universities that we gave training activities and collaboration with them. The hotline, drug combating high council, the matrix program and the screening training as well, and the medical student affairs department for anti-drug prevention activities. Thank you very much.
Thank you, Professor Samir. I think any questions? I think we still have some time for questions. أي أسئلة يا جماعة؟ I have one question for you. What about the advanced research? You didn't mention anything about your activities and the neuroimaging and.
Yeah, we could spend all day talking about this topic, but as I mentioned, research comes at many levels. So we need all forms. We need social research. We need, but one of the areas that I'm particularly interested in is in the area of biology and in neuroimaging. So if you're interested in some of this, if you Google Enigma, E-N-I-G-M-A, that's the world's largest collaboration of neuroimaging research in psychiatry. I'm very fortunate that I chair one of those divisions, but we have, I think, over 100 countries now that are involved with that. So what we're finding is that looking at the genes, So there's the GARS, the Genetic Addiction Research Screener, that's out there. I can bring that here to Egypt for free. We can work with your university to look at that. So we have genetics research, we have proteomic research. So what are the proteins that are being developed that might be affecting addiction? My area that I've had interest in is in connectomics, how the brain talks to itself. And what we're finding, and this is a white matter issue, not a gray matter. So we learned in neurology, white matter, with gray matter lesions associated. What we're seeing here is that you do not find a signature gray matter lesion in the area of addiction. What we have been able to demonstrate is that the brain's ability to communicate with itself is affected. And so what we're doing is a number of advanced imaging techniques. And we would love to partner with you on that. Again, this is the world's largest collaboration. And why I think it's important is the more we understand about the biology of addiction, we can decrease the stigma. Because it's not that people actually choose this, that it's a chronic illness that we need to treat. Because the stigma, I think, really, really complicates the treatment. People don't want to go into treatment because of the stigma. The family doesn't want to. So I think the more we understand the biology, that this addiction is truly a brain disease that affects the biopsychosocial aspect of the patient, then I think that we're able to do, and it's, again, we need many, many samples. So what we're looking at is the combination of genomics, and there are a number of very important candidate genes that we've identified. We can actually screen for them. Very simple clinical screening we could do in the clinics, very easy to do. A high school student could help do the screening. And then looking at white matter connectomics, particularly looking at the amygdala and the hippocampus and the white matter connections to the prefrontal cortex, which are largely mediated through dopaminergic activity. So I think there are many, many opportunities for us to work together on this. And we can do a lot of the analysis because we have a bit more in the way of supercomputer technology, but we work together as equal colleagues in trying to understand this. But I really believe that we really need to look at the biology and then how it impacts on the clinical care of patients and their families.
Oh, now we have good questions. Abdurrahman.
What about the role of cannabidiol in treatment of opioid addiction? And is there any promising drugs for treat opioid addiction?
It's an excellent question. So the question was the role of cannabinoid oil in the treatment of addiction. This is a very controversial area. I don't think we have enough of the science to really answer that. There are many reports that we're seeing in the literature over the past few years talking about the role of cannabinoid oil in treating addiction. And then we have other reports that say not so much. My opinion is there are likely some individuals who would be able to benefit from cannabinoid oil, but not all. So this is where we need a lot more research, because I believe in some individuals we might actually make it worse. Some, it might show some improvement and be part of an effective treatment strategy, and some probably no effect either way. We don't know which patients are likely to benefit from it and which patients are likely to get worse. So this is why we need big clinical trials with good epidemiologic prospective. So it's again, we're seeing more and more reports in the literature. I don't know we have the final answer yet, but I think this is an important area. Again, helps us to understand the biology behind addiction. So excellent question. The matrix model you mentioned, actually that is our, matrix is, that's our group. So the matrix is Western U, we write grants together. So the matrix group, we can bring them over here. You can hear it right from the Dan George who developed it. He reports to me. So I can say, come over and help work with our Egyptian colleagues.
I think
One of the areas of interest that I've been in contact with well in work as well, mindfulness. And I actually met Dr. John Kabat-Zinn,
Yeah.
and other professors there in Mindful Institute. Did you have any experience with the mindfulness role in treatment of drug addicts?
Significant. So my son, who's also in psychiatry, as was my father and grandfather, there's probably a gene to want to become a psychiatrist. We just haven't found it yet. That's my son's, one of his areas of he did his thesis was in mind. I think it's a very important part, maybe one of the most important. And again, when we talk about addiction, we talk about, you know, medications, but it's like a good soup. A good soup is not one ingredient. A good soup is many ingredients mixed together at the right way. So I believe mindfulness and motivational interviewing are critical. And we incorporate those into our training to get some experience. So we actually have, on some of the online, they'll have a patient and you'll observe and it will stop and then the student can pick, and then based on what they pick, it will give a different response. It's computer adaptive learning. So mindfulness is very, very important. We use it all the time. I think it's one of the most effective. I must say that although the 12-step programs, AA, are very, very popular and I think have an important role, I have some concerns with some of the AA issues. I think some of it is excellent, but I can't say I buy all of it. We use bits and pieces. The support is good. You know, bringing in spirituality, I think, is very good. Some of the issues, I don't think fits every patient, but mindfulness, motivational interviewing, very important. I would love to see how it varies in a different culture, how it works here in Egypt, because you have very different cultural beliefs. And does it make it better or worse? But in my belief, it's one of the most important pieces.
We have actually experienced, we applied a program here for drug addicts, for those who stay for 4 weeks in patients, and we compared between those who entered in the program, mindfulness, we got a program, we translated it.
Mm-hmm.
And we imaged the brain before and after, and we compared this for those who didn't enter in this, and it was a thesis and the thesis. And there was another collaboration with somebody in Germany, and it was a very good result of brain changes, functional, and we are working now on the structural changes after 4 weeks. With decreased craving and things.
It's so important because we think that if you don't take a pill, it's not real. But there's very good data to show that effective psychotherapy, as far as the brain concerned, is just like effective treatment affects how the brain works. What we've had some good success is combining motivational interviewing and MAT with CBT, the combination of treatments. We found that in many of our addicts, psychodynamic therapy is more challenging for the addict because of the level of denial. Not that it can never work, but what we found is motivational interviewing along with combinations with a kind of a modified CBT for substance abuse can be very effective. And again, there's very good data, if you look at the Enigma data, showing that you're changing the brain, so this is an effective treatment strategy. So it's very good studies, and I think we need to expand those. Thank you.
حد عنده سؤال بالعربي عايز يسأله من الإخوة الأخصائيين أو من الزملاء؟ حد عنده سؤال بالفرنساوي عايز يسأله؟
My question is, during the whole meaning of the word here in Egypt, we do sudden discontinuation of substance and symptomatic treatment for the withdrawal symptoms. We cannot afford for methadone or Suboxone or something. So my question is there is any way that midway between here and USA, like giving methadone, Suboxone for the first few days to overcome the withdrawal symptoms and then continue our program, or it doesn't work?
That's a very good question, because the idea is, do you get an advantage of using Suboxone or methadone and have it, it's certainly a little easier for the patient. Now the question is, if it's easier for the patient, does it affect the long-term outcome? And that's a very good question. I don't know if we've got, there's anecdotal reports. I don't think we have really good data. There's certainly no overwhelming data to show that the use of medication-assisted treatment, you know, naloxone, Suboxone, methadone, it's certainly easier for the patient. But I'm not sure anyone can demonstrate that you must use that to get a better outcome. I think it's where, again, I think what we're going to find is there's probably a group of addicts who that will make it easier so that you can have more effective treatment. I don't believe it's a one-size-fits-all. I mean, if you wear a size 42 shoe, someone gives you a 48 or a 38, not so good. I think we have to get the right size to fit the patient. And I think some patients, there might be an advantage to using, but there's no data to show that by not having methadone, you're not going to be as effective. The key is you need to get them detoxed, get them through physically, but the key really is the long-term treatment. So what happens at the back end is probably a lot more important than what happens at the front end to just get them off the medication, get them detoxed. But it's an excellent research question.
I would like to ask about, unfortunately I didn't attend, but the discussion is very stimulating. I'd like to ask about the programs about the addiction female addicts. The pregnant female addicts.
Oh, yeah.
During pregnancy, and what is, if there is research about this area, caring about the mother and the child during this very critical area, which could be a turning point in the outcome for the offspring.
I actually didn't talk about that during the lecture, but I have significant experience. That's one of the areas I researched when I was in the NIMH. So it turns out with women in addiction, women are more likely to have an adverse effect and become addicted when they use in the late luteal phase, those 2 weeks before the onset of menses. You know, we know about PMS and PMDD. It turns out that biologically, we have changes in pharmacokinetics and pharmacodynamics, the metabolism and distribution of drugs of abuse in about 8% of women worldwide, not just in the US, so 5 to 8%. So women have some very interesting and unique biological as well as psychological. We know oftentimes women, their responsibility is the children and the household. So we can't factor out the psychosocial from the biological. We know that the response to most treatments, including psychosocial, varies to some degree on menstrual cycle phase. And what that has to do is in the neuroendocrine cascade, from the hypothalamus down to the gonadotropins to the gonadosteroids, estrogen, gonadosteroids, feed back onto the POMC gene in the base of the brain, which has a direct impact on metabolism. So that issue, there's much work. In fact, many of the studies that are done, if you don't control for menstrual cycle phase, your data is somewhat flawed. Now, the other part of your question is a very tragic one, but we know that women who use, babies are born addicted. They detox at delivery. Very, very, very tragic scenario. We're trying to follow a cohort of babies who were born. There was one study that I was involved with over 20 years ago now, looked at women who were cocaine addicts. And we were able to follow their children for 7 years. And what we found of those children who were born of mothers who were using cocaine, 8 times the likelihood to develop ADHD. They were much more likely to develop substance abuse themselves later in life. We believe that was a sensitization kindling phenomenon that we see, for example, Bob Post's work from many years ago. So we know that mothers who abuse, very, very toxic. Not only do they detox at delivery, but they change the biology of the brain. And again, the thing that we've seen most of the literature has been dramatic increase in ADHD, usually manifesting around 8 to 12 years. We were able to follow them out about that long. So this is a very, very important area. Working with OBGYNs and the role of substance abuse, we know that substance use during the first trimester has the greatest impact on organogenesis. So that depending on when they were using, will have an impact. Last trimester, the infants were born with addiction, but we seem to have less changes in organ development. But this is a very, very, very important area that is, I think, quite honestly, is understudied and needs to be a clinical. So we need to be working with our colleagues in the OB clinics and screening and then following those children. It's very tragic to me that a child is born, but I think all the more reason that we need to intervene as early as possible, working with our child psychiatrists and our pediatricians and our neonatologists. Very, very important area.
They continue in this area. We don't see addicted females with pregnancy and giving birth to addicted children or addicted babies. We don't see this in Egypt. What's the cultural difference? Abortion is legalized in Europe and the States, and the American ladies, for example, are not keen for children. And why they keep children, why they keep pregnancy after addiction?
Well, actually, under President Trump, not my favorite guy, but he has actually changed. So abortion, they're trying to get rid of it. It was the Roe v. Wade was the legislation many years ago that legalized abortion. It's actually, they're trying to turn that around. So what I think is, it would be a very important study. It seems that when the woman is using and how much they use has an effect. But this is why I say it's such an important area for research, because the reason you're saying that the women don't use when they're pregnant, or
if they are pregnant, in Egypt they go for abortion immediately.
Oh, so you can get an abortion in Egypt?
Yes.
Here I
in Egypt, illegal abortion.
Oh, illegal abortion. Well, I mean, if the baby's aborted, then you're not going to see, obviously. But the problem we see is many women will start using, and when they find out they're pregnant, they stop. But they've already been pregnant for 6, 8, 12 weeks. So a lot of the damage has been done. So, but this area of drug use, and drugs are different. We know cocaine versus opioids versus, that not all drugs are the same effect on the fetus. So this is a very, very important area that I think has been understudied. And I think what we need to do is to partner with the OB nurses, with obstetricians, with pediatricians, psychiatrists, child psychiatrists, family physicians. This is a very important area that is not anywhere near as well studied as it should have been.
I think we have a small project concerning this hearing with the pregnant female addicts in Egypt, and actually it needs start with raising the awareness and the knowledge about the OB, even physicians, because and the pediatricians, because it is extremely neglected area, and they tend to overlook, and even they don't ask about the history of the substance abuse. But what you added to me more, that it is not about taking care about the area of pregnancy and giving birth, and also we have a deficiency concerning who will care about these offsprings after delivery. But you add more that it needs more follow-up,
Yes.
just to take care about these offsprings for
Yes.
for the future. Yeah.
And the other thing that we know is that women who are addicts, they don't take care of themselves as well. They don't go to their OB appointments. They don't take their prenatal vitamins. Their diet might not be very good. They're not sleeping well. So it's not only the drug, but it's all the things associated with being an addict. They're not taking care of themselves. And we know that not taking care of yourself is not taking care of your unborn baby. So this is why we need good data, because there are many factors that we need to go in. So if a woman is an addict, but is eating well, is sleeping well, is going for her prenatal visits, is that going to be different than the woman who does not take care of herself and shows up, ready to deliver and have to not conceive? So these are very, very important questions, but I think you're right. We cannot stop at delivery, or we need to follow these children and make sure that because there might be the ability, if we intervene earlier, to decrease the downstream, the long-term effect. So we need these prospective trials. We need to identify these children as at risk so that we can develop some appropriate interventions earlier on, which actually would be cost savings because it's much easier to treat earlier than when they themselves become addicts.
Professor No is responsible for the National Survey of Drug Addiction with
Beautiful.
MOH, and they did a sample of over 100,000 Egyptians, and those results I provided you with Jonathan was from those studies.
So I think those are the types of trials we need, big, 100,000, 200,000, but we have to make sure that we collect the data properly, or we end up with type 1 and type 2 statistical error. So once we see were they addicted, but then we need additional study. The age, younger women who are addicted and deliver seem to be different than a woman in their 30s or older. Nutrition, sleep, socioeconomic status, history of other mental illnesses, depression, psychosis, anxiety. These are data, so good data, we need to get as many demographics as we can, and it's difficult when you have large studies, but the more we can get, we can understand the relationship between these variables and then long-term outcome measures. And we would love to work with you on collecting these data and then analyzing them. But we have to be cautious to get as much as we can. If not, we might come up with conclusions that were really better addressed by looking, well, it wasn't the opioid, it was the fact that she was, not taking care of herself, not eating properly, under a lot of emotional stress. Emotional stress is a very significant toxic impact on a fetus. Emotional stress because, increase in cortisol levels, that we know mothers who were highly stressed during pregnancy, for whatever reason, their babies have a whole host of increased physical illnesses related to the hypercortisolemic state that the infant lives in, during gestation.
It will be our pleasure.
Thank you very much. Thank you for the speakers. Thank you, Sir Barwon. Thank you, Professor Mack. And thank you for the audience and the wonderful discussion. I think we have a small buffet waiting for us.
Is that okay? I had to show, but I'd rather sit around with the audience. No, no.